Toon, and I'm hopefully chairing the session this afternoon, and hopefully you're all hearing us and seeing us well through this webinar that is an APSAD and Australian Smoking Cessation Professional webinar. As you know, this is one of the very first ones where we've been doing using this newer facility, and we hope this goes well, and we'll be having obviously more presentations and more interesting, not more interesting, sorry, Gemma, but interesting presentations to have you look at in the future. But it is absolutely seminal to all of us, in fact, to hear Gemma Hemshaw as one of our first presenters on this webinar facility that we've got. We'd like to thank Kevin Price in particular and the group from the Seventh-day Adventists who are financially and technically supporting this. Gemma is the tobacco portfolio manager at the Cancer Institute, and she looks after the New South Wales Smoking Cessation Framework. So this is a program and a framework some of you may have had some input into or may have never heard of it. And therefore, as I said, one of our most important first up presentations is to have an idea and of the concepts of the cessation framework for New South Wales, so that, again, other states might have an important model for this around Australia and, in fact, around the world. So I'll now hand you over to Gemma. I would like to suggest that if there are any questions, that you might leave it for the end. If there are any technical questions, usually it's not our capacity to do anything about the technical part. Usually it's sound or whatever it is, it's usually in the ether, and there's not much we can do about it. Hopefully you can hear us well, and I'll open now to allow Gemma to present this particularly important framework for our state of New South Wales. Thank you, Gemma. I'll pass it over to Gemma. Yeah, sure.
Hello, everyone, and thank you for joining today. I just want to start by, I guess, acknowledging the traditional owners of the land on which we meet and pay my respect to elders past and present. And I wanted to just say, if anyone can't see here or see our screen, just pop in the questions and we'll try and help. But yeah, thank you for joining and letting me tell you a little bit about the work we're doing. So I'm the tobacco portfolio manager at the Cancer Institute, New South Wales. And one of the key pieces of my work is looking after the New South Wales Smoking Cessation Framework. And so this is a new piece of work that we launched earlier this year. And I guess my kind of plan for today is just to give you guys a little bit of background about where it came from, how it was developed, and how we are kind of starting to work in this space. And if any burning questions come up as we go through, do feel free to pop them in the comments box, or we'll open for questions at the end. So if my screen works and I can flick through the slides, we'll see. Yes. Okay, so the first very exciting first slide is just talking about the smoking cessation policy context in New South Wales. So in a nutshell, pretty much every policy that has anything to do with tobacco says that we should be providing brief interventions to help people quit smoking as part of routine health care. It's in the New South Wales State Health Plan, a New South Wales Tobacco Strategy, the New South Wales Cancer Plan, and we also here have the New South Wales Smoke-Free Healthcare Policy, which states that all clients and patients should be asked if they smoke, and if they do smoke, they should be provided with support to quit. So that is a good base, a good policy base to say this work should be happening. However, the reality on the ground is it's not consistently happening across New South Wales at this stage, and there's, I guess, a lot of opportunity to be doing a bit more work in this space. And so I think I'm guessing I don't need to say anything to this group about why smoking cessation is important, not only for long-term health, but also for clinical outcomes. And so what we, have started doing is having a look at what's currently happening, trying to look at what the data is telling us. And I think probably one of the very key early learnings in this is there is very little data about what's really happening in clinical practice. And the data that we are kind of pulling is looking at things like activity-based funding, quick-line referrals, health professional training, and trying to, I guess, piece the puzzle together to work out what is happening and identify some opportunities of how we can work better, we can work in this space. And so from that, the smoking cessation collaboration for New South Wales was commenced probably about 2 years ago, and it brought together representatives from across the health system and a few key NGOs to talk about how the health system could be doing a better job of supporting smoking cessation. And the framework was the kind of key thing that came from the collaboration. So it's basically a tool that aims to progress systematic change by identifying the key enablers at all levels of the health system. And I guess it's kind of in a nutshell is ideally we want clinicians on the ground to be providing smoking cessation support, and there's lots of barriers around why they aren't currently doing that, very valid things around not having enough time, maybe not feeling confident or not having had the training, etc. But there's also lots of enablers that really will support clinicians to be providing that support. And so what the framework really does is bring together those enablers into a framework. And so the way it was developed was through a really comprehensive evidence review, which included the New South Wales Ministry of Health 2016 exploratory study, which was called Investigating the Management of Nicotine Dependence and Smoking Cessation in New South Wales Health Facilities, literature review of other practice change initiatives, and then significant consultation with representatives from across New South Wales Health, from clinicians and directors in pharmacy and JMOs, etc. And that consultation and evidence review, again, really brought all those barriers out, but also really focused on looking at what the enablers were. And so the enablers were basically synthesized into 4 implementation strategies, as we're calling them. And it's not rocket science, these are quite obvious, but I guess it's a nice way of trying to bring that evidence together and really highlight what the evidence says is important. And so the first is leadership and governance structures. And I guess, as we all know, if it's coming from the top, if leadership is saying this is something that's important, if there's governance structures around making sure something is happening and creating that accountability, things are more likely to happen. So that is obviously a really important piece of the puzzle. The second one is a smoking cessation coordinator. And the evidence says that in health districts where there is dedicated positions to supporting smoking cessation, then more support will be provided. We definitely debated when we were creating the framework whether coordinator or coordination was the right word, because I guess not everyone currently funds a coordinator, and not everyone necessarily will. And the idea is that the coordination of smoking cessation is happening. I guess this is a summary of the evidence, which does say having dedicated roles is key, and so we've included it for that reason. The third of the implementation strategies, the blue on this slide, is identify, train, and support staff. And this is obviously a really key big area, and it's making sure that the staff know what their responsibility is, know whether they are the person who's supposed to be providing support and what that looks like, is trained appropriately and supported appropriately through access to NRT, the appropriate policies, appropriate time within their job, etc., to do what they need to do. And finally, the last one is establishing accountability mechanisms, and it's kind of the age-old what gets measured gets done, and actually trying to track what really is happening and really improving the data that we have around this, and then using that to feed back up into leadership and governance structures and really support this work happening. And it's probably worth me pausing at this point and just I guess emphasising that what we are hoping to happen is clinicians to be providing brief interventions. We're not expecting that every clinician across every part of the New South Wales health system is going to become a smoking cessation expert, but just that they are able to ask someone if they smoke, advise them and assist them. So the framework, if anyone would like copies of the framework, we can get your addresses and after this and send copies out to anyone else who'd like to see them. It's also available online, so we can make sure you guys have that link following this webinar as well. But what you'll see is within this framework, it's basically in those 4 sections. And for each of them, there's a list of suggested action. And we I guess they're calling this a bit of a choose your own adventure, with the idea that ideally everyone everywhere should be putting all of these things in place and implementing all these actions to be doing the best job they possibly can. The reality is some people are doing some of them already, and some people will see others as a bigger priority, etc., depending on local needs. So suggested actions are just that, suggestions, and people can pick and tailor and choose from those where they want to start or what they see as the biggest priorities. So, for example, a couple of these this was from leadership and governance structures, and one of the actions is promoting the importance of smoking cessation with management in all relevant forums, such as senior management meetings. So some of them are quite straightforward like that. Others, the fourth one down on the left-hand side here, about establishing appropriate LHD governance structures with senior executives as chairs, etc. So most of the actions, when they're kind of broken down into this sort of level, are more straightforward. Some are more complicated, but it's kind of, I guess, a tool that outlines what the evidence says and some of the actions that people can be doing from that. So what we are also doing, so the idea with the framework is it's a tool for local health districts. They can take that, they can, I guess, work through some of those strategies and actions to make that system change that will support smoking cessation. But what we're also really mindful of at the Cancer Institute and the Ministry and all of the other health pillars that are involved in the smoking cessation collaboration is it's not, unfortunately, so simple as creating the framework and running away, and that we need to do a lot of work around supporting this and working with the local health district and with other stakeholders. And so this slide is a lot on one slide, but basically it's kind of outlining some of the other things that we're going to be working on over the coming years to support this where we can. And so the first is probably where we currently still are predominantly, is stakeholder engagement, is making sure that everyone knows the framework exists, they understand it, they're thinking about how they can use it, and we're tying it into relevant policies and strategies and things, and making sure people are aware of it. So there's a lot of work still kind of happening in that space. The next part of this diagram is the LHD, the local health district planning workshops. And so what we've basically offered is to run a workshop with any of the local health districts in New South Wales, and we've done 2 so far, where we bring together senior managers to talk about smoking cessation, how they can use the framework, what they see as the current priorities, what they're currently doing, what a government structure might look like for them, and kick them off on the journey and try and provide a little bit of support to kind of, start people using the framework as a tool. The third one on here is around supporting priority settings, and within the health system, priority settings we've identified at this stage are cancer services, maternity, drug and alcohol, and mental health. There's obviously lots more we can be doing, but they are some of the few that we are going to be doing a little bit more with in the initial instance, and I'll tell you a bit more about the cancer service work as in a second. The next is EMR integration, and this is something that we can crack it, will be our really, really big win. In the minute the electronic medical records have some fields around smoking cessation, and some of them are being used by some people some of the time, and we currently don't have sight of what data is currently being collected, completeness of those fields, whether they're actually the right fields, whether there's the appropriate prompts. People can't currently make referrals through our electronic medical records to smoking cessation specialists, and so there's a lot of opportunity to make sure that medical record system is doing a better job to support people. And so we are starting to engage with eHealth, look at how we may want to change the electronic medical records to do a better job of supporting clinicians on the ground in terms of referrals to quitline, appropriate prompts, the correct information going into discharge letters, the fields being in the right place, being easy to complete, etc. The next thing that we're going to start looking at is health professional training, and so there is lots of training going on around the state around smoking cessation, and obviously Renee here is definitely been doing an amazing job of training lots and lots of people around it. What we're mindful of is there is a lot of people in the state who maybe have not received training, or I guess we're keen to understand what is all the training that's currently available to people in New South Wales. So that would be New South Wales training, but also Australian training and maybe training from overseas that people are accessing. Is that currently meeting needs? Are there gaps? We've got a HETI, the Health Education Training Institute online smoking cessation training module. Is that meeting people's needs? Are people doing it? And so what we want to do is just at this stage just pause and scope what's happening in the training space. What is anything else needed? Is it just that people need to know what training is available? Do we just need to do more to promote it? Do we need to fill any gaps, etc.? The next one is establishing a clinical community of practice. And this is something the ACI, the Agency for Clinical Innovation, have said they will look after. And the idea is smoking cessation, as you will all know, is very often a population health issue, less so a clinical issue. And so what we are really trying to do is engage as many clinicians working in this space who are interested and, you know, keen to do more around smoking cessation, to be coming together and talking about how they can also be supporting the health system, and what currently, I guess, sharing best practice and establishing that community of practice. So that's something that hopefully ACI are going to be kicking off in coming months. And so if anyone on the line is in New South Wales and a clinician and interested in joining that, it would be great to hear from you, and we'll, I guess, soon as that kicks off, we'll link you in. The next one is communication strategy, and this ties to stakeholder engagement, but I guess takes it a little bit further in. I guess we need to try and make sure that we're communicating with kind of the different levels of stakeholders around smoking cessation, around the framework, around the various bits and pieces of work we're doing, because there's no point us doing something and not telling anyone else. And so we're, I guess, starting to work on what our communication strategy is, how we, you know, talk to people across every part of the health system around the importance of smoking cessation and what we're doing, what everyone else is doing. The next is business cases. And so one of the key things we are keen to try and support is local health districts to support local health districts in doing this work, is help identify, are there any opportunities for any business, or do any business cases need to be made? And one of the key things we've just started to look at is activity-based funding. And at the minute, from the initial look at activity-based funding data, most people are not claiming activity-based funding for the smoking cessation work they're doing. And so we're keen to, I guess, dig into that space a bit more, work out who is claiming it for what. Could people be claiming more? Do people know they could be claiming it? And I guess do what we can in that space to maybe help make business cases to fund smoking cessation coordinators or NRT, etc., for example. And then the final part of this, obviously, is framework evaluation. So at the minute, we are, I guess, establishing our overarching evaluation framework and looking at what data sources might be available for us to be tracking over time in terms of things like, are we seeing more training being taken up? Are we seeing more NRT being provided, quitline referrals coming through, etc. So that's going to keep me busy for a while. And then just I guess for you guys a little bit more about the cancer services work we're doing. And so obviously, as the Cancer Institute, we are really well connected to cancer services, and there is obviously a significant amount of evidence that shows that smoking cessation is really important for cancer patients for their cancer treatment outcomes. And the stats on this slide here are from the 2014 Surgeon General's report that show the causal relationship between cigarette smoking and all-cause mortality, cancer-related mortality, and cancer recurrence. And the stat at the bottom, which Graham Warren, who is a radiation oncologist from the US, was over here for the Cancer Institute conference last year. And one of the things he talked about, and I'm still waiting for him to publish something to this effect, but was that for every 3 to 5 patients that don't quit, one will die, have the cancer reoccur, or have toxicity as a result of not quitting. And he was very passionate about Centrum getting some of you on this webinar will have been at his presentation. And if not, it's also on the Cancer Institute website, so we can send you the link to that if anyone wants it. But it was really powerful, talking about the importance of smoking cessation for cancer patients, and definitely converted a lot of people who I've met with since then, who have really been excited about the opportunity to be doing more in this space. And so we have tried to kick off a project to work really closely with the cancer services in New South Wales, so to support them to be providing smoking cessation support through the implementation of the framework. And so we have a network there called the Cancer System Innovation Managers, who come together and work collaboratively across the state. And we have recently engaged them and are currently in the scoping and kind of kick-off phase for a new project working with them. And what we've done is basically identify 7 of the actions within the framework that we I believe are the biggest priorities, which I'm not going to be able to remember all of them now, but they include establishing a governance structure, a communication and change management strategy, establishing who is responsible for smoking cessation coordination, if not recruiting a coordinator, identifying and training staff, I can't remember the others, but along those lines. And so the hope is that we're going to work together over the next kind of 1 to 2 years to start implementing those different things within their cancer services, and I guess be tracking and monitoring and making sure that people are uptaking training, that communications are being rolled out about the importance of this, so that clinicians are aware of what of the importance of smoking cessation, that they know how to provide a brief intervention, that NRT is available in those services, etc. And I guess, just provide that extra bit of support to kind of drive that work in that setting. So I think I did one slide, which was just a mini overview of the project. So at the moment, we are in the go live phase and planning for implementation, with the view that through 2019, it'll be implementing the framework strategies. And also one of the key things we're really trying to set up with this project is implementing opt-out referrals to New South Wales Quitline. So that's something that Graham had done a lot of research around, and there's a lot of evidence around that if you tell someone to call the Quitline versus if you make a referral, then you're much more likely to get them to actually link to the Quitline if you make that referral. And if there's a mechanism that makes that an opt-out referral, and I think the way Graham kind of talks about it is saying, asking someone if they smoke, and then saying, the most important thing you can do for your cancer treatment outcomes is to quit smoking. I'm going to refer you to the New South Wales Quitline. They're going to call you and provide you the support that you need to do that, And so that, from his research, that's hugely effective at getting people the support to help them quit. And so that's something we're going to be looking at how we can implement in New South Wales. So that's kind of a bit of an overview of the framework, some of the work that we're doing to support it, and the background and things. But I'm, I guess, keen to hear from you guys. Any questions? Have you seen it before? Have you, what work's currently happening in and around Australia in this space? Yeah, if you want to type your questions in, I think I should be able to see them coming up.
I guess maybe to start the ball rolling, I might ask a question, and that is really to do with positions and support, clinical support. You mentioned tobacco treatment specialists, referrals to, and even the Quitline is looking at, difficult cases. We have more than 50% of the people calling the Quitlines are very difficult, complex, comorbid cases that often are not easy to treat, and often a referral is required to somebody who is on face-to-face potentially, or how do we get support for more clinicians on the ground, financial support, I mean.
Yeah, it's a really tricky thing, and I think at the minute we have had a lot of conversations, and I'm guessing probably with some of the guys who are on the line today, around the role of Quitline versus face-to-face support. And at the minute, there are some pockets and some LHDs that have that face-to-face support on the ground, but it's not consistent and it's not across everywhere. And so we are strongly advocating that the key referral mechanism is to the Quitline, as in it's statewide, it's equitable, it's everywhere. However, if LHDs and services have face-to-face support, fantastic, brilliant, and referring people to those is great. We know some of the local health districts are doing some work around looking at activity-based funding to fund those positions. And so that's something I guess there's lots of things, the more we kind of work in this space, the more we hear things that are going on and are trying to find mechanisms to harness that. And what we've been asking people to do is write up case studies of things that they're doing. So anyone else doing anything great here as well, would love to hear your case studies so that we can be sharing those. But I think the obvious mechanism is funding. For there to be funding, activity-based funding is likely to be a key way of doing it. I know one of the health districts has set up a clinic that's therefore able to provide that support and be funded through activity-based funding for doing it, and they're just in the initial phase of kind of working that all through. So hopefully there are mechanisms for that.
Yes. I think that it would be really wonderful to have literally, as you say, case studies of how you can do that, and to make it more available to us in our group and our groups just generally around the state, so that people, or the country really, so that people know that you can actually do that you can be self-funded if you set up a clinic. It doesn't require the hospital or the clinical setting to set up something special and fund it independently. It can be self-funded if you know what to do. The question is, perhaps we can develop something that people know what to do, how to go about using various codes in medical records, so that people who are seen one-on-one or in groups even you can code for that, and you can establish a fund for that, and then become self-funding. We need to show our colleagues, I think, how that can be done, and that it's doable.
I think it seems like quite an untapped opportunity, and I'm still only just exploring it and really keen to learn more. So if anyone knows much more about activity-based funding, would like to come and talk to me and tell me everything you know about it, that would be really helpful, because I'm keen, if that's an avenue that we aren't using, it's full opportunity that we find out as much as we can about it and we start using it.
Yes. Has anybody out there got any questions they'd like to type in? Not sure how many people we've got live online, but and do remember this is recorded, so you'll always be able to look at this presentation in the future, at least for a month, as it's recorded, so you can show it to your colleagues or to your managers of your department. Might need to know a bit more about this topic, which is really important for us in terms of, as I said, planning and implementation. I think it's a hugely important topic. I don't know if we're getting any questions.
Can I just ask a question, and I guess type in your answers if it's okay. Have many people on this line, on this webinar, heard of the smoking cessation framework before today? And has anyone been using it or heard anyone talking about using it at all?
People just, I don't seem to be seeing any response.
Yes, quick Taz here. Hi. So yes, Sue, you're saying yes, you had heard of it before.
Thank you.
That's good to know. That's good. Yes. Good. Okay, that's good. Anyone else?
It'd be interesting to know what you think about any dilemmas you've got with any of this.
Sue's saying, I hope I'm not the only one here. You're not. It looks like there's 17 people on, so I'm hoping other people can hear us.
We'd be very interested to know if you've got any criticisms, if you don't mind me saying. What about some criticisms? What do you think of the review and really the framework? What do you think? Because some of us over the years have been there a bit before with this, and we've often had significant stumbling blocks. In particular, I think, if you don't mind me saying this, there's been up until recently an objection to seeing smoking and the treatment of smoking as a medical entity. That most people can quit on their own and they don't need any help and they don't need pharmacotherapy. And there's been a bit of a stumbling block, which I think has been there, well, let's just say more than a decade of that. But I think that's changing now. It's become evident that people are having trouble. It's not as if it's a one-size-fits-all anymore. I think we've been able to recognise that there are smokers who can be given a little staff, a little bit of brief intervention, just even asking if they smoke does something. But then there are the others now that we know are more difficult to treat. So we've had this sort of framework set once before, and it really came to a grinding halt because of the inability of some of our more senior colleagues, if you like, thinking that maybe this isn't appropriate for this behaviour. Do you think times have changed?
Well, I don't know. I guess I wasn't around for when that happened before, and so I can't probably comment on that. I guess I'm hopeful that we can, and keen to do everything we can. And sorry, we've got another question coming through. Do you have a sense of how many dedicated tobacco treatment specialist smoking positions New South Wales has? I would say it's less than 10.
Oh no, there'd be more than that. If you don't mind me saying, I think there are more than that.
Dedicated positions.
Yes.
That's probably why I don't know.
There would be more than that, but what we need to, I'd say that there's at least 20.
Okay.
Oh yes.
Okay.
But what we do need, which I did actually request of the federal government, is we don't have a very good handle on how many there actually are nationwide, and how many patients can you refer somebody, and you can today, to say somebody at in the North Coast. You can. There are GPs who are specialised in this, and there are addiction medicine doctors now.
Is there a list?
And there isn't a list.
Okay.
And what we desperately need is a list of. We have tried that with our association, and of course our association membership. So that's national, and we certainly have in the hundreds of national members. So statewide, we do have a lot. Oh yes, we would have. We just don't have the ability to coordinate that, and I think that's perhaps something we should be looking at, putting together a list of who can the quit line, if needs be, refer somebody to locally. We've had that ability to do it with our old association. You could look up somebody near you, and perhaps some, bypass. We don't want to bypass the quit line, but maybe somebody outside of, or had an experience with the quit line that they'd rather do a face-to-face. And there are definitely GPs, there are definitely addiction medicine specialists today who specialise not solely in nicotine addiction, but are highly skilled at it.
Yeah, and I guess outside of New South Wales Health, but within within health.
Yes.
I think, Amy, are you New South Wales yourself? Do you know much more about the tobacco treatment specialists in New South Wales? Or you're in the ACT?
Yes.
Okay, and do you know how many there are in the ACT?
I think there would be at least 4 or 5 in the ACT, Amy.
3 currently.
3 currently. There you go.
Okay.
All right. Okay. Well, that's good, considering, and when we're talking statewide, we're looking at a substantial amount of people. I think perhaps we ought to do a call for who is.
It would be good to have that list. I hadn't, quite appreciated,
there's more than you think, actually.
Yeah.
And sometimes it's not dedicated entirely to, but would be in drug and alcohol.
Oh, you're saying there's a few more now. It's a shame that private tobacco treatment specialists are unable to write a script for PBS, NRT, or to bulk bill patients. Is that something that's likely to change?
Yes. No. I don't. Very unlikely. Though we do have trained tobacco treatment specialists who are nurse, clinical consultants, nurse practitioners who can do that. And in fact, I recently met with somebody who can do that. So remember that. Keep that in mind. Nurse practitioners can do that.
Sue's saying, I guess there's a lot of prioritisation going on with health professionals across individuals, and smoking's not always the priority. Disappointingly, but understandably. Yes. Yeah. It's the prioritisation of smoking is it's really challenging, definitely. Sorry, I'm trying to get to the last one. So I agree with the last question. NRT should be free. We've co-created this situation over the decades. It's still a barrier along low socioeconomic. Yeah, I completely agree. And I think I've heard people making the argument of, but it's cheaper than smoking, so that's the answer. And it's not. Oh, it's not. It's so frustrating because obviously that's not that simple.
No, not our patients.
Yeah.
I wanted to remind everybody that in terms of treatment, and we're probably digressing here a little bit from the framework, but in terms of treatment, it isn't just NRT. And remember, I've got no conflicts of interest with the drug companies that make varenicline, but varenicline is really an excellent treatment, and it would be my first choice. And so it's subsidised heavily. It works extremely well if it works. And remember, we don't blame the patient if it doesn't. It's got to do with how they receptor responses to this product. So we're a bit over, let's just say overdosing with, not saying overdosing with, you know what I mean, not overdosing with, but using it. The focus is on NRT, and it doesn't have to be that way. And possibly it shouldn't be that way because we've got other products that work really well. And if you're a good therapist and you're a good clinician, you should be able to discern what's most appropriate for the patient. And the NRT may not be, and certainly not one form of it, not anymore. So keep in mind, there's many sorts of treatments available today, and there will be newer ones coming.
Yeah, I'm quite interested to know how many GPs are doing smoking cessation training and really upskilling themselves around pharmacotherapies for smoking cessation. How much is really known in that area? Because I don't know about that.
We do our best. The College of Physicians had a program on it, and so it was online, and there were hundreds of GPs logged onto it. So the College of Physicians, both state and federally, are very interested. GPs are now increasingly more interested because it's healthy lifestyle medicine is becoming important, because as you've probably seen recently, a good proportion of the people who come to a GP today have got, if you want to call it, lifestyle medicine concerns. It's either obesity, diabetes, heart disease, and COPD, and how much of that is related to smoking? Well, probably 3 out of 4. And so behavioural lifestyle is huge in medicine today, in general practice. So I'm personally engaged a lot with training GPs at the moment, right now. So it's
good to know. Maybe just put primary health staff. Sorry, can you see the last question?
So many health staff still give varenicline a bad rap, though. Really, I know. I came across it recently in somebody. I'm sure you've seen it too, who should know better. I've heard it from the mouth of a CEO of a very big medical complex, public health complex, saying, "Oh no, we won't use that. We don't want suicides in our patients." And I just shake my head. It's terribly misinformed, and we need desperately to manage this better. The misinformation is one of our biggest problems, as you all know. And so I think part of our training and upskilling, or at least part of the training and upskilling from the point of view of this framework, is to debunk misinformation. And because patients, frankly, as we all know, their lives are at stake. This isn't a minor issue, as we all are passionate about. This is a major issue. I was at if you don't mind me an anecdote, somebody very nicely said to me at a reunion to do with what was called then the Cameron Wing at St Vincent's Hospital. So this dates from the 1960s, when we had the very first heart transplants in Australia at St Vincent's Hospital. Some of you know where we started the very first smokers clinic. And somebody very nicely, as a chest surgeon, a heart surgeon, came up to me and said, "Your group and you have saved more lives than anybody here at the heart transplant. It all looks lovely, heart transplant, coronary artery grafts. But the reality of what we do in smoking cessation saves many more lives." And that's very nice to hear, and acknowledging that prevention is the cure, and those very expensive interventions are very romanticised and look great. And of course, if it was your family member, you'd appreciate. Yeah. But the reality is that we all save a great deal more lives doing this, and we really need to perhaps reinvent that, reiterate that to our colleagues who, for reasons beyond me, maybe have forgotten that. There's a bit of forgetting the history. Yes.
Any other questions from anyone else?
Well, thank you everybody for logging on. We want to remind you that this is being recorded and that our very next presentation is in October, on Tuesday the 30th of October at 12 o'clock. And I'm hoping for something special on that day, and I'll let you know as soon as I know what's happening on that day. Something a little special. And I want to reiterate for yourselves too, those who are listening in and logging on and perhaps hearing this later on as a recording, if you have projects that you'd like to showcase, if you've got projects that you'd like to talk about, or a particular concern that you might like to talk about, or for example, would you like some presentation on a particular topic that maybe needs reviewing, I'm very happy to source that information, source somebody who could present on it. Please let us know. Me in particular, Kevin, also Kevin Price, or APSAD, let us know if there's a particular topic of interest for you that you might like to hear about. We're very keen to hear what you need and how to keep you better informed. So thank you, everybody. I think we'll log off now and see you next time. Bye, everybody. Thank you again, Gemma. Thank you so much.
Thanks, everyone.
And thank you, Kevin.
Thanks. Bye.
Bye.